you very much, dear colleagues and Dr. Abdullah for the invitation. So I'm just going to talk about the evolving strategies for antithrombotic therapies in patients with coronary artery disease. I was asked to talk about the various stages of coronary artery disease. So the platelet is actually a complex structure and has multiple receptors and requires therefore multiple drugs to block the coagulation cascade. So we have the aspirin, which is the COX-2 inhibitor. We have the ADP receptors antagonist, and we have glycoprotein receptor antagonist. Those are the most commonly used antiplatelets. So there are a lot of studies throughout the years from 1970s when the Grunting did the first angioplasty. They used aspirin first, and then there was invention of other drugs throughout the years to reduce the risk of stent thrombosis, which actually the balloon angioplasty thrombosis. So the heparin was used before, the warfarin, and then teclopidine, and then clopidogrel, ticagrelor, prasugrel, all of these through the years, trying to identify the best strategy and the best duration of anti-thrombotic or antiplatelet treatment. So, and all of this is just to reduce the risk of thrombosis. So for the stent in particular, so the stent thrombosis risk is actually a serious problem, and all of us who are doing intervention, or even the colleagues cardiologists, we have seen patients with the stent thrombosis and like catastrophic outcome. So why do we give antiplatelets for a long time, and why do we have to give it in general? So it's basically we want to reduce the thrombosis risk. And so that risk of thrombosis is probably the most likely to occur in the first 2 months, first 2 months post-stent implantation. Plaque regression and destabilization of the plaque, it will take maybe between 2 to 3 months. Prevention of future events is ongoing problems, as we discussed earlier. So even the mild coronary lesions can actually can rupture and cause thrombosis. But the bleeding is a very, very important. And the bleeding risk, again, is most common perhaps in the first year, but is a continuum. So these are the trials of, this is actually only a snapshot of the trials. So there are a lot of trials to try to optimize the duration of dual antiplatelets. So like 12 months, 6 months, 1 month, 3 months, and there are some conflicting results based on perhaps the type of the coronary artery disease, whether acute coronary syndrome or stable angina, and also the type of the stents. So in general, the guidelines would suggest the following. So for stable coronary artery disease, aspirin only is the recommendation. During PCI, you would add clopidogrel. Perhaps you continue for 6 months or longer. In patients with non-ST elevation myocardial infarction, aspirin again has a class 1A indication before the angioplasty or before the coronary angiography. You do not give routinely P2Y12 inhibitors, and this is clear in the guidelines, has now class 3A indication. But during the PCI, if we continue with PCI, you would give clopidogrel or ticagrelor. It depends on the local guidelines, but the international guidelines is actually recommending stronger P2Y12 inhibitors. The duration again varies, but in general, you would give 12 months if there is no high risk of bleeding. In patients with the STEMI, so that's a different category. You would give right from the start, when you diagnose it, you would give combination of aspirin and potent P2Y12 inhibitors, and you continue with 12 months. So, but is this actually, so the 12 months duration, can we apply it to all patients? No, I think we have to, as physicians, we have to personalize our treatment. So not all patients are the same. We have high risk bleeders. We have patients who had, for example, like a very stable coronary artery disease, even if they come with acute coronary syndrome, but they have a single lesion with a very large stent, very good flow. So you know from the start that the risk of stent thrombosis is extremely low. And then those patients, perhaps you would reduce the duration of dual antiplatelets. You have patients with high risk of bleeding. So I think personalized treatment is very important. And like we get a lot of calls the patient has not completed yet 12 months, and I think then therefore the judgment would come into consideration. So what about aspirin? Aspirin has been largely omitted now from a lot of studies and has not actually shown to affect the outcome in terms of ischemia, but rather actually reduce the bleeding. And this is the two largest trials, Global Leaders and Twilight, which show that actually omitting aspirin after 1 month or 3 months is actually beneficial and reduce the risk of bleeding. Now, in general, when we do PCI or patients with acute coronary syndrome, say even stable coronary artery disease or acute coronary syndrome, we will do the procedure, and then we would tend to score them like the bleeding risk. We have a precise DAPT score and DAPT score after 12 months. So if the risk of bleeding is low, then you would continue for 12 months as per guidelines. And then at 12 months, you do the DAPT score again. If the bleeding risk is low, you could continue for 30 months. So we want to protect the stent, but also we want to protect the patients. So we have to balance the risk of bleeding versus the risk of thrombosis. So in the first months, perhaps, it's mandatory to give dual antiplatelet if you can. At 3, 6, or 12 months, you would assess the risk of bleeding, and then you would continue for 12 months or extend beyond 12 months if your risk of bleeding is extremely low according to the DAPT score. I'm just going through some of the guidelines. So patients with acute coronary syndrome undergoing percutaneous coronary intervention, if the bleeding risk is low, so if no bleeding, they don't have any features of high bleeding risk, including the old age, previous bleeding, low, like anemia below 11, you would give them dual antiplatelet therapy with aspirin and ticagrelor or aspirin and prasugrel for 12 months duration. This is standard treatment. You can shorten this to 3 months of dual antiplatelet and then omit aspirin after that, according to the 2 studies, Twilight and Global Leaders. If the bleeding risk is high, then you would give probably the combination therapy for 1 month, and after that, you can give single antiplatelet, and preferably to give clopidogrel or ticagrelor instead of aspirin. In patients with stable coronary artery disease who have, so like we call it chronic coronary syndrome, who have percutaneous coronary intervention and no prior MI, again, ideally, if there is no bleeding risk, you would give them for 12 months. But here the guideline says aspirin and clopidogrel rather than ticagrelor or stronger or potent antiplatelets. If the bleeding risk is high, you would give dual antiplatelet for 1 month. After that, you can switch to any of the antiplatelets. Now, patients with the chronic coronary syndrome and they have prior MI more than 12 months, and if they have high bleeding risk, again, you would give aspirin and ticagrelor as per recommendation. But now, after 12 months, so if the bleeding risk is very low, you can continue with ticagrelor 60 milligram twice daily, according to the Pegasus study, for perhaps 30 months or 2 years. If the bleeding risk is high, at 12 months, you would switch to single antiplatelet, of course, and that would be clopidogrel or ticagrelor over aspirin. The studies show clear that the clopidogrel beyond 12 months is superior to aspirin. What about patients undergoing coronary artery bypass surgery? We don't see them that much, but in general, if they have acute coronary syndrome and they go for cabbage, they have no high bleeding features, they would continue with dual antiplatelet for 12 months. But if they have high bleeding features, you give them for 1 month and then you continue with single antiplatelet for 12 months duration. I'm going to skip this. So in general, my strategy for antithrombotic treatment, minimum dual antiplatelet for 1 month, commonly 3 to 12 months, depends actually on many factors. Clopidogrel as single antiplatelet, I give it after 12 months. And aspirin, I would use the approach less is more. So less aspirin is better. If you can give it for 1 month only is enough. Beyond 12 months, I don't tend to give aspirin. Now, I have one case quickly to present. 52 years old male with late presentation, anterior STEMI, and severe heart failure. ECG showed the anterior Q waves. His BMB was more than 4,000. His troponin was more than 3,000. So he had a large anterior infarction. He was started on aspirin and Brilinta and low molecular weight heparin, heart failure therapy. His echo showed severe LV dysfunction. Ejection fraction was less than 20% with large apical thrombus. Coronary angiography showed 3-vessel disease. He was scheduled for cabbage. Just only 1 minute, or yeah. So I will just show you his, 1 second, yeah. So that's his coronary angiography. So he had 3-vessel disease, 1 second, just. So 3-vessel disease, LAD occluded, right occluded, and severe stenosis in the circumflex. So I think coronary artery bypass surgery was in the MDT meeting discussed, and he agreed for surgery. And that's his echo showed severe LV dysfunction with LV thrombus, large thrombus. So what is the optimal antithrombotic therapy in this case? So we have triple therapy, warfarin, aspirin, ticagrelor, triple therapy, DUAC, aspirin, and ticagrelor, triple therapy, DUAC, aspirin, or clopidogrel, or dual therapy. And I would leave this question for discussion. Thank you.